Thanks very much. It's been lovely to be here today, and it's been a great program that's been organised by Rebecca. I'm just going to talk a bit about the current landscape of treatments in MS, a little bit about the particular challenges of progressive MS, which I think we've heard quite a bit about today, the current options for progressive disease that are licensed, and one potential drug that isn't licensed that is showing quite a bit of promise at the moment. I'm going to make reference back to the MS STAT2 trial that was completed last year, but the main focus of this presentation is about the OCTOPUS trial, the particular design of that trial, the rationale for the drugs that are under study, how we're getting on with the recruitment to date, the future for OCTOPUS in terms of the next few years, the next stage of the trial, and a little bit about biobanking and sub-studies that are related to the trial as well. So the landscape for DMTs in MS has really been transformed over the last 30 years or so. The first drug to be approved was beta-seron, interferon beta-1b in 1993, approved by the FDA, and that was fairly quickly followed by approvals for interferon beta-1a and then for Copaxone. Since then, there's been a succession of drugs that have been found to be effective, both during the duration of this timeline and actually more recently as well. Despite the fact that these drugs, the interferons and Copaxone, were approved in the early to mid-1990s, they weren't actually widely used, certainly in the UK, until the 2000s. And the reason for that was because the NICE determined that once the drugs were clinically effective, they weren't actually cost-effective. So in response to that judgment, the Blair government of the time in the UK, together with pharma, got together and developed a risk-sharing scheme, which subsequently ran for 10 years. It recruited 5,000 patients over that 10-year period, and these were patients who were treated with interferon or Copaxone. The final report from that 10-year evaluation was presented in 2018, and that identified that those DMTs were not just clinically effective for MS, but they were also cost-effective in slowing down the progression of disease in patients with initially relapse-onset MS. There was a 28 to 31% reduction in EDSS worsening and a 4-year time delay in reaching an EDSS of 6.0. So even these relatively modestly effective drugs had a significant impact on disease progression. I think everybody in the audience is already familiar with the different disease patterns, and indeed we've seen representations of these in recent presentations. 85 to 90% of patients start out with relapsing, remitting MS. About 10 to 15% have progressive disease from onset with no real relapses. And then we have this really difficult group in the middle that we've heard a lot about, that unfortunately 80 to 85% of the patients eventually migrate from having relapsing remitting disease to secondary progressive MS, usually over a period of 20 to 25 years. And they hit that phase of secondary progressive disease even where there seems to be lower amounts of new disease activity on MRI, and despite the fact that they're having fewer and perhaps even no relapses at all. And the reason that's happening is because of the decreasing brain volume. We're all experiencing that, and unfortunately I'm quite well advanced along the scale here and experiencing that more than most in the audience. But in addition to that, there is a supercharged decline in brain volume that occurs in our MS patients. And that progression and evolution is sadly reflected in how too many of our patients progress along the EDSS scale that's already been shown by some of the earlier speakers. The EDSS does have its limitations. It has particular limitations in terms of detecting cognitive problems, and I'll show a slide in a moment that actually illustrates that. But lower ends of the scale, scores of 1 to 2, patients may have minimal disability, the middle part of the scale having difficulty with walking, and then at the upper echelons of the scale, wheelchair dependent with scores of 8, and then bed-bound with a score of 9. This interesting study from 2020 illustrates the difference between chronological age and biological age in MS. It also highlights some of the deficiencies in the EDSS scale. And it does this by taking 4 clinical examples and comparing the chronological age of the individual with their biological age. As you can see, this is a patient with clinically isolated syndrome, not meeting diagnostic criteria for MS as yet, and their chronological age and biological age of their brain is very similar. The next patient, though, is a more difficult scenario. A patient with relapsing or remitting MS, just age 31, they've had MS for 7 years, EDSS score, relatively favourable, just 2.0, but already their brain predicted age is over 40. So that's a considerable gap between chronological and biological age. And the picture is even worse for patients with secondary progressive MS and primary progressive MS, where the gaps are 15 and 18 years for patients in their 40s. So this is the impact that disease progression and brain atrophy has over time. The good news is that there are interventions that we can make that can change the clinical course of MS. And that is to an extent illustrated by the risk-sharing scheme that I showed earlier on. And there's good evidence that intervening early, even around the time of diagnosis, can make a substantial difference to the clinical outcomes for patients. Early intervention is better than later intervention, and later intervention is better than no intervention at all. The holy grail for MS treatment, and for clinicians like me and for patients, is NIDA, no evidence of disease activity. Now, the traditional model of NIDA, or NIDA 3, is that there are no clinical relapses, there's no disease progression, and there are no new lesions on MRI. There are, however, other parameters of NIDA, and these have been referenced, I think, already today, with the importance of brain volume, discussion about neurofilaments and using that as a marker of disease activity, and also the importance of cognitive impairment and neuropsychological assessments. As reflected in the previous DMT timeline, there are now lots of drugs available as disease-modifying therapies for patients with MS. Because of this, patients can be exposed to a variety of different treatments over the clinical course of their condition. And this graphic is taken from a study that explored the experiences of one particular cohort of MS patients. In this particular group of patients, the injectable therapies were most commonly used as the first drug, but then over a period of time, patients were increasingly being exposed on a second or third occasion to higher efficacy medications such as natalizumab and fingolimod. The authors of this study used it to try and answer the question as to whether these high-level disease-modifying therapies actually make a difference. And in this study, they did find that that was the case. If you just look at the first drug, where patients were exposed to a treatment of moderate efficacy, such as beta interferon or Copaxone, they achieved NIDA in year 1 and year 2 about a third or a fifth of the time, whereas when exposed to drugs of higher efficacy, such as natalizumab or fingolimod, NIDA was achieved much more frequently, and that was statistically significant. And the same was the case with the second drugs that patients were exposed to, where again, high efficacy medications were statistically more likely to produce no evidence of disease activity compared with those drugs such as beta interferon and Copaxone. There was no statistical difference when they compared third drugs, but that was probably because of the smaller number of patients involved in that cohort. Just to illustrate the current profile of disease-modifying therapies in a typical population on this island, this is the DMT profile for us in Northern Ireland as of February of this year. Currently, we have about 5,500 patients in Northern Ireland with MS, and currently, as you can see, there's approximately 3,000 patients on some form of disease-modifying therapies. That's approximately 55% of the MS population. We still have a significant number of patients on the first-line injectable therapies, but that number is gradually declining over time. And we now have over 1,200 patients on higher efficacy therapies, such as anti-CD20 therapies, natalizumab, and some of the other second-line oral agents, such as fingolimod. That's about 41% of the overall DMT population. And again, that number is gradually increasing over time. I'm just going to illustrate the challenges that patients feel and experience in the real world with progressive MS. And this is going to be illustrated with one particular example who attended me a number of years ago. This is a 24-year-old lady who first attended the MS clinic in late 2009. On examination, she had significant deficits. She had bilateral internuclear ophthalmoplegias, she had ataxic spastic paraparesis, she was dysarthric, and she had cognitive impairment. On initial questioning, the onset of her MS appeared to have been in February 2007. At that stage, she had developed some numbness in her right arm and then over the right side of her torso, and that resolved over a period of about 3 months. Then, in very early 2008, she developed numbness and weakness in both legs. She was treated with steroids with really no benefit, and her legs began feeling tremulous in bed. During 2008, she had diplopia for several weeks, and by the time of the presentation at the clinic, that was still occurring episodically. When we went into the history in a bit more detail, however, it seemed that she'd actually experienced symptoms as far back as the year 2000, when she was just aged 15. But the investigation at that time had unfortunately been very limited. There'd been a feeling that she might have a functional disorder or a peripheral neuropathy. So this was her imaging in 2009, and as you can see, hopefully appreciate, a very high lesion burden in the brainstem, in the cerebellar hemispheres, and also in the periventricular white matter. Unfortunately, subsequent to that attendance at the MS clinic, she had little response to IVNP or rehabilitation. She was commenced on beta interferon. She briefly regained ability to walk a distance of a few meters. That was followed by further decline. In 2010, she fell and fractured her hip. By 2011, she was executing sliding board transfers. In 2012, she had a baclofen pump inserted to try and better manage her spasticity. Her family at that stage were requiring respite care for her. In 2013, she had a supraclavicular catheter inserted. 2014, a PEG tube inserted. By 2016, she was arthric. She had limited awareness, and she needed full-time nursing care in a neuropalliative care facility. And by September 2018, she was deceased at the age of just 33. Thankfully, that doesn't reflect the journey of too many of our patients, but it is an example of some. And certainly a lot of our patients end up with similar levels of disability, perhaps later on in life. There are treatment options available now that might have been available to her, but obviously they were only approved long after she had passed on. There are 2 drugs approved for progressive MS. One for primary progressive MS is ocrelizumab, or also known as Ocrevus. It's an anti-CD20 therapy, and it's given by a 6-monthly infusion intravenously, and more recently a subcutaneous product has become available as well. There's also a drug approved for secondary progressive MS, that's siponimod or Mayzent, which Fiona mentioned earlier on. It's an S1P receptor modulator, particularly binding to subtypes 1 and 5, and it's administered by daily tablet. The evidence for ocrelizumab comes from the Oratorio study, which was a placebo-controlled trial published in the New England Journal of Medicine in 2017. And that found that, compared with placebo, there were statistically significant benefits for ocrelizumab, both clinically and radiologically, in terms of the time to confirmed disability progression at 12 weeks or 24 weeks, but also in terms of significant improvement in terms of the volume of brain lesions on MRI, but also a reduction in the rate of decline in brain volume in the ocrelizumab group. The evidence for siponimod comes from this paper in The Lancet, from the EXPAND trial that was published in 2018. Again, it was a double-blind, placebo-controlled study showing a significant impact on disease progression, finding that there was a significant impact of siponimod in terms of disease progression, both in terms of reaching confirmed disability progression at 3 months and at 6 months. So those are the only 2 drugs currently approved for the management of progressive MS. But there is a promising newcomer that was published just a couple of months ago in the New England Journal of Medicine from the Hercules trial, and that's tolebrutinib. It's a Bruton's tyrosine kinase inhibitor, which particularly acts on cells that affect smoldering neuroinflammation, which are a particular driver of disability in MS. This was placebo-controlled. It was in a non-relapsing secondary progressive MS population. And it was found that there was a 31% reduction in the progression of disability in the treatment group compared with placebo. In the same journal, the Gemini trials were also published. These were slightly different. These were trials comparing tolebrutinib against teriflunomide, which was an approved and known to be effective disease-modifying therapy for those with relapsing-remitting disease. Whilst it wasn't found to be superior to teriflunomide in terms of reducing relapse rates, interestingly, it seemed to have a superior effect in terms of reducing disease progression. So tolebrutinib is likely to be something that you hear more about in the months and years ahead. I'm just going to reflect back a little bit on the MS STAT2 trial that Fiona mentioned earlier on, in which we were involved in Belfast, along with about 30 other centres across the UK. I think when the MS STAT2 trial was first envisaged, it was hoped that there would be a centre in Dublin. That didn't happen. Sadly, Brexit happened in 2016, and that made a lot of those sorts of arrangements very difficult. Some people say that that's a Brexit benefit. Most sensible people feel that it isn't. So that trial was in non-relapsing secondary progressive MS. It was for patients aged between 25 and 65 with an EDSS score of 4 to 6.5, so patients who were still ambulant and who were not already on a statin. And the patients in this trial were exposed to simvastatin at a dose of 80 milligrams daily. So why were statins used? Well, for all of the reasons on the left half of this slide. And the other good reason that they were used was because previously there had been a phase 2 study, the MS STAT1 trial, which appeared to show that simvastatin had a significant impact in terms of reducing brain atrophy. Ultimately, the study ran between 2017 and 2024. The chief investigator was Jeremy Chataway, who's pictured here. There were 964 patients recruited. There was a huge exercise. It was certainly disrupted to an extent by COVID, but got through all of that. The results were presented in Copenhagen at ECTRIMS last September, and sadly the result was a negative one. There was no effect on disability progression. So whilst there may be many merits in the use of simvastatin, there's no potential role for using statins as a disease-modifying therapy in MS. The same sponsor for the MS STAT2 trial, at the time that was still ongoing, was also making plans for a further trial called the OCTOPUS trial. This is fully funded by the UK MS Society. The MS STAT2 trial had also been partly funded by the UK MS Society, as well as the National MS Society in the United States and the National Institute for Health Research in the UK. But this one is fully funded by the UK MS Society. What does it stand for? Optimal Clinical Trials Platform for Progressive Multiple Sclerosis. The trial has had quite a lot of publicity, including around the time of its launch in April 2023, and this is taken from the BBC website at the time. And maybe try and remember that date in the context of another slide I'm going to show a little bit later on. It's still getting a lot of publicity, and this is a screen grab from a Channel 4 programme that went out just a few weeks ago, again featuring the OCTOPUS trial. So what is OCTOPUS? It's a multi-site, UK, multi-arm, multi-stage trial looking at the slowing of progression of disability in patients with progressive disease. It's a randomised trial, there's double blinding, and there's placebo control included in this as well. The objective is to assess the efficacy of treatments that target neurodegenerative, neuroprotective, and remyelinating pathways in MS. In terms of MS, it has a unique trial arrangement. There's a control group, and there are two simultaneous treatment groups. The trial is divided up into 2 phases. There's analysis stage 1, which includes MR imaging, and then there's analysis stage 2, which does not include MRI. When all of the patients in the first stage of the trial have gone through that, had their MRI scans done, and that'll probably be sometime in the middle of next year, the MRI analysis will probably prompt one or other of these active treatment limbs to leave if it's found to be ineffective, and at that point, other treatments can be slotted into the study. Other potential treatments of promise, either known about now or that emerge over the next couple of years. So what are the advantages of this MAMS trial design, multi-arm and multi-stage? Well, several treatments can be tested at the same time against a common control. Treatments that appear effective from the early data can go into the next trial stage without having to start a new trial, so that's the multi-stage element of it. The data can be analysed while the trial is ongoing rather than just at the end, and early decisions can be made about the efficacy of the interventions. And as I've said, when new information about different treatments becomes available, where there are already treatments of promise, these can be added into the trial if the initially active treatments are found to be ineffective. The MAMS trial design is unique to MS, but it's not actually unique to neurology, and there have been more than 80 randomised trials around the world using a MAMS platform design over the last number of years. And these have found promising therapies for the management of cancer and have also helped to identify effective vaccines, including the COVID-19 vaccine. So how were the drugs being used in OCTOPUS actually identified? Well, in 2018, the UK MS Society set up an expert consortium to select already licensed drugs that had potential as disease-modifying therapies in MS. And if you look at all of the names on the expert consortium, you might recognise some of them, including our own Denise Fitzgerald. Sadly, Denise can't be with us today. There was a treatment selection group, there was also a treatment advisory committee, and there were various subgroups of those groups and committees. They went into a detailed process of analysing and considering a number of potential therapies and effectively drew up a dossier or CV for each of the potential candidate DMTs. They went into a modified Delphi analysis of those options, and ultimately they came up with a final selection of 9 different drugs that seemed to be of particular promise in progressive MS. Ultimately, the top 2 selections were alpha-lipoic acid and metformin, and those are the 2 drugs that are currently being used in the OCTOPUS trial. So your reaction to alpha-lipoic acid is probably, what is it? And that was certainly my reaction when I first heard about the OCTOPUS trial. Interestingly, it's already a drug that's used in Germany. It's licensed for the management of peripheral neuropathy in that country, but not used here. It's an enzyme-bound cofactor with a lot of different biological functions, and this is where I get very nervous about talking about basic science in a room full of basic scientists. But anyway, these are some of the multiple biological functions. It's a free radical scavenger. It's involved in lipid peroxidation reduction. It modulates mitochondrial dehydrogenases and glycine cleavage systems. It's involved in tissue regeneration and metal chelation as well. What does it actually do? It's involved in mitochondrial protection. It helps to stabilize the blood-brain barrier. It reduces free radical oxygen species. And something that Eric was talking about earlier on, it helps to reduce toll-like receptor expression. In addition to that, it's also anti-inflammatory. How does it do that? It helps to inhibit nuclear factor kappa B, which again we heard about earlier on today. It's involved in the regulation of apoptosis, and it's a regulator of intracellular free radicals also. It's also been found to be useful in a previous study. This was a study published in 2017 of just 51 patients with secondary progressive MS, aged between 40 and 70. There was a 68% reduction in the percentage change or deterioration in brain volume in patients who were treated with lipoic acid compared with placebo. So there's a real-world clinical example of how lipoic acid, alpha-lipoic acid, can actually work. What about the other drug? Well, the other drug is metformin, which is much more familiar to clinicians like me, being used very widely in the management of diabetes. It was first introduced to treat diabetes in France in 1958. It was first synthesized in 1922, apparently out of a folk medicine knowledge that the drug seemed to treat people who had sweet urine. It's a synthetic biguanide. So what does it do? Well, again, this is where I'm getting into basic science territory, which is never that comfortable. But its main primary target is through the mitochondrial respiratory chain complex 1. It's been demonstrated to stimulate enhanced mechanisms of remyelination by increasing oligodifferentiation, increasing oligo numbers, and increasing the numbers of myelinated axons. Again, it helps to support blood-brain barrier integrity, it inhibits neuronal apoptosis, and like alpha-lipoic acid, it also has anti-inflammatory properties, which it mediates by inhibiting pro-inflammatory cytokines and by also increasing T regulator cells. So what about the eligibility for the OCTOPUS trial? That's a bit about what we're using and the basis for that, who's eligible for it. Well, again, the eligibility substantially hangs on the EDSS scale. And the eligibility is that patients need to have a score between 4 and 8. A score of 4 means that a patient can walk about 500 meters. A score of 8 means that a patient is essentially wheelchair dependent but has some useful upper limb function. There are other inclusion criteria. Patients need to have a definite diagnosis of MS, and they need to be in the secondary progressive or primary progressive phase. They can be aged between 25 and 70. So most trials, as you'll be aware, in MS tend to have a cutoff of 65. This one is pushing it a little bit further. The Chariot MS study that Fiona mentioned earlier on, actually, again, in secondary progressive MS, didn't have an upper age limit. So these trials are starting to push the boundaries of that. Patients need to have adequate renal function and satisfactory liver function. And certainly for the first phase of the trial, they need to be willing to have MRI scans undertaken. The exclusion criteria include patients who've had recent relapses, patients who've got significant comorbidities, which obviously is an issue given the sort of age that we're often dealing with, and patients who are in the progressive phase of MS, patients with malabsorptive problems such as celiac disease. If pregnancy or breastfeeding is likely or actually current, then again that would be an exclusion criteria. Recent treatment with steroids, recent treatment or current treatment with either of the 2 drugs under study, and also recent commencement of a disease-modifying therapy or treatment with famotidine within 26 weeks of randomization. There are 2 modes of entry to the trial for potential participants. All participants need to express an interest in being entered into the trial, and they can do this either through a dedicated registration of interest page or through the UK MS Register portal. And they can access that through that particular website. When they go in there, they'll be faced with a page where, if they're already on the MS Register, they can log into the MS Register and go in through that portal, or they can alternatively register their interest separate from that. As Fiona's already mentioned, once they've registered their interest, their names will appear on a database. We're notified in Belfast about patients who are potentially within our catchment area, and then they can be pre-screened as to whether they might be eligible for the trial. Up until September 2024, so that's about 6 or 7 months ago now, there have been 6,000 registrations of interest for the trial. Now you notice that there's a big peak there, and that's around about April 2023. Well, that was the time that the trial was launched, and that was the time of that information on the BBC website that I showed earlier on. And there have been one or two other peaks at different times when there's been promotion in local media, perhaps associated with sites opening as well. Currently, there are 15 OCTOPUS sites. The Celtic fringe is well represented. There's one in Scotland, there's the site in Belfast, obviously there are two in Wales, but they're all dotted all over England, north, east, northwest, Midlands, south, and obviously in London. And there are 3 other sites that will be opening in due course if they haven't already done so since I prepared that slide. In addition to there being those 15 sites, within that there are also 4 hubs. There was an application process in 2022 which advertised the potential for additional funding to be available on the premise that those applying could reach enhanced recruitment targets. After that application process was completed, we were fortunate enough to be one of those hubs, together with colleagues in Leeds, Coventry and Warwickshire, and in Southampton. Now, with that hub status comes a number of other obligations apart from the enhanced recruitment. We need to engage with other centres in our catchment population, and we've been doing that with colleagues outside the Belfast Trust and the South Eastern Trust and in the Southern Trust. And MS nursing teams across all of Northern Ireland have also been engaged with OCTOPUS. We're obliged to publicise the trial within regional networks, and again we've been doing that through QUB, through the Belfast Trust, and through the local MS Society. And it's expected that there should be integration between research and clinical settings. And again, obviously with the Fitzgerald lab being on our doorstep, that has made that very easy to do. And of course, we need to have the capacity and resources to screen the necessary number of patients. This is a picture that you've already seen today. We do the trial in the clinical research facility in the university floor of Belfast City Hospital. These are some of the members of the team, and these are some of the facilities that we use. I mentioned that the trial is occurring in 2 stages. There's analysis stage 1, which includes MRI, and the primary outcome measure is the whole brain atrophy rate as measured by an automated technique called Sienna. There's a whole array of secondary outcome measures, other MRI outcome measures, clinician-reported outcome measures that you can see, all of the familiar sorts of outcome measures that we use in trials, and then there are patient-reported outcome measures also, and again, you've heard 1 or 2 of these referenced a little bit earlier on today. In analysis stage 2, there's no MRI, and the outcome measures are clinical ones, and the primary outcome measure is progression of disability as defined by progression on at least one of 3 parameters related to the EDSS, the time 25-foot walk, or the 9-hole peg test. And again, there are secondary outcome measures, none related to MRI, but this includes some health-related quality of life questionnaires also. The assessment schedule is reasonably demanding for patients. Apart from the pre-screening that might be done down the telephone by the research nurses or an outpatient clinic, there's also a screening visit undertaken, and if that is successful, within 4 weeks of that screening visit, patients are randomised to the trial. 4 weeks after that, if suitable, they go through a dose escalation phase, and then there's an assessment at 12 weeks over the phone, then at 26 weeks, 52 weeks, 78 weeks, and then at 104 weeks. In phase 1, there's an MRI scan before randomisation, and then at week 26, at week 78, and week 104. And patients are really committed to quite a long time in this trial. They'll remain in it for up to 5 years, unless the arm that they're on closes or they withdraw from follow-up. In November of last year, the UK MS Society was delighted to be able to announce that recruitment to phase 1 of the trial had been successfully completed, and indeed had been completed somewhat ahead of schedule. Recruitment in the first year of the study, up until December 2023, was relatively slow, with about 100 patients just over being randomised. But then during 2024, that really increased. And ultimately, 375 patients, which was the target, were randomised to phase 1. Now, as of November of last year, 8 of the patients randomised had withdrawn. 367 were continuing in follow-up. 21 of those were no longer, however, on one of the trial medications. So there have been 29 withdrawals from the trial, either in terms of just stopping the INP or withdrawing altogether. And these are the various sites that those 29 patients are located. And there have been many different reasons for that to happen. In terms of the baseline characteristics of the 375 patients, this has been an overwhelmingly white population, 95% white. Females constitute 60%, and secondary progressive patients are 62% of the initial cohort in phase 1. Patients are on average about 20 years since disease onset, and they've been progressing in terms of their disease for an average of 10 years. Being on a disease-modifying therapy is not an exclusion criteria for coming into the trial, so about a quarter of patients are on a DMT whilst also being on trial medication. And many of those will be on siponimod and ocrelizumab, but also 1 or 2 other drugs as well. 70% of patients have an EDSS score of 6 to 6.5, but there is a spread of EDSS scores right across the range, between 4 and 8. Just to give you the latest update in terms of recruitment, this is sort of hot off the press from last month. We've now moved from 375 patients being randomised to there being 490 randomised in the trial. And this is the league table, if you like, of where patients are being recruited from. Unsurprisingly, UCL are leading that table, rather like Liverpool in the recent Premier League. They've got an unassailable lead over everyone else. We're positioned in 3rd place, so rather like the Premier League, we're in good competition for one of the Champions League places at the end of the process. The hubs that I mentioned earlier on are all quite prominently placed: Belfast, Southampton, Coventry and Warwickshire, and Leeds in terms of recruitment to the study. And actually, since that slide was prepared, I think we have moved from 49 up to a figure of about 55. So where are we now with the OCTOPUS trial? Well, phase 1 ended in terms of recruitment, at least, around about November last year. In January, stage 2 opened. Obviously, the patients who've been recruited to stage 1 will be going through that for a couple of years, and they'll be having MRI scans undertaken. So once that analysis of the stage 1 data is done, that MRI data is done, it may be the case that one or other of these drugs will drop out and they'll be replaced by something else. And that replacement process will probably happen in the 3rd or 4th quarter of 2026. Apart from the ambition to identify effective therapies for patients with MS, the OCTOPUS trial also has ambitions to identify biomarkers that can predict long-term disability and also predict the response to treatment. So with this in mind, we're also collecting blood samples at various time points, a DNA sample on one occasion, and then other plasma and serum samples at week 0, week 26, week 52, and week 78. And there are 4 centres involved in this biobanking process, and rather neatly, I'm not quite sure whether it happened by accident or by design, the 4 centres represent the 4 constituent parts of the UK: Edinburgh, London, Cardiff, and ourselves in Belfast. It may be that at some stage in the future the number of sites will be extended, and indeed that the time points for sampling will also be extended. And there is the potential to combine with other cohorts which have significant biobanks as well, such as those related to other trials, including MS STAT2 indeed, and trials such as Deliver MS, which are ongoing as well in the UK. Apart from the ambition about biobanking and having a biorepository samples, OCTOPUS, as we've heard earlier on from Laos, also want to support other studies that could advance our understanding of the condition and our understanding of those mechanisms underlying progression and also markers of progression. So there is a process by which investigators can submit proposals to OCTOPUS to become involved in the study in terms of using some of the data coming from the trial. All of the proposals and proposers should have scientific merit, be suitable. Proposals should be suitable to answer the research question in mind. They should have sufficient resources available to complete their project and be suitably qualified to perform their own analysis as well. There is an oversight group that considers applications for these sub-studies, and there are various principles underlying the considerations that they undertake. So far, just 2 projects have been awarded sub-study status. You've heard from Laos and the Belfast eye study, which is now linked to this. And there's also a digital monitoring study, which is being driven by colleagues in Sheffield. This is the trial management team for OCTOPUS, led by Jeremy Chataway, a really supportive group and a pleasure to work with, as was the case in terms of the involvement with MS STAT2. So in conclusion then, there's been significant progress in terms of treatments for MS over the last 25 years, which has been very positive. There are still significant gaps in terms of what we can do even for patients with relapsing remitting MS, and there are certainly gaps in treatment options for those with more advanced disease. And of course, what we want to do is get to a position where we can stop patients actually getting into that progressive and disabling phase of the condition. OCTOPUS is providing a novel approach, at least in MS, with its multi-arm and multi-stage arrangement, the platform approach with biobanking and sub-studies. It's dynamic and flexible. Hopefully we'll get quicker results, both positive and negative. And it's also setting new standards in patient involvement and engagement, and a new way of actually recruiting patients to the trial also. Thanks very much for your attention, everyone. Happy to answer any questions.